Good afternoon, everyone. Welcome back to Medicine Grand Rounds. I'm your host, Lekshmi Santhosh, filling in for our chair, Dr. Wachter, while he's away today. It is my true pleasure and honor to invite Dr. Dean Schillinger, an amazing speaker for our Grand Rounds today, to teach us all about the art and the science of listening and how to optimize the clinical encounter with this free, low cost intervention that we can use to actually transform our communication with patients and families. So Dr. Schillinger is the director of the UCSF Communications Health Research Program, and he serves as a UCSF primary care physician, a scientist, an author, a public health leader, and truly an international expert in health communication. He's the inaugural holder of the Andrew B. Beinman Professorship in Primary Care and Health Policy at UCSF, and he co-directs an NIH-funded center to promote diabetes-related health equity. He also served as the chief of the UCSF Division of General Internal Medicine at ZSFG and of the Diabetes Prevention and Control Program for the California Department of Public Health. He co-founded UCSF Action Research Center for Health Equity, a leading research center really committed to address the social, environmental, and commercial determinants of health. And you may have seen a recent New York Times article talking about his critically acclaimed and best-selling book, Telltale Hearts, a public health doctor, his patients, and the power of story. Here to tell us more about the power of story, Dr. Schillinger. Thank you so much.
Thank you, Lekshmi, and hello to everyone, especially those on Zoom. Today, I'm going to be talking about ways to optimize the clinical encounter by reviewing what we know about the science of listening. These are a couple of my patients who've given me permission to reproduce their photos in front of our clinic. People I listen to probably every 2 or 3 months. So I'll start by talking about the hot topics in health communication that I will not be discussing. So health communication has been a backwater field for decades. No one's funded it. No one's really cared about it. It's been thought of as this crunchy granola activity that really isn't worth investing in from the NIH standpoint. And then suddenly, a renaissance happened, and everyone's talking about health mis and disinformation, communication via secure messaging, AI, LLMs, and health communication. And we've had a number of recent grand rounds, as recently as 2 weeks ago, that have covered some of these topics. So while I could have given grand rounds on one of these topics, I chose not to, and rather focus on an area that's near and dear to my heart, so dear to my heart that, as Lekshmi mentioned, I wrote a book about it, which is what we can learn when we bring together the alchemy of story and science, what we can learn about how best to take care of our patients when we listen to their stories and merge it with the best of our science. And when we aggregate all of those stories across time and across populations, what those stories tell us about public health. And that's what my book is primarily about. Now, the irony, of course, is that after I wrote that book, I asked myself, well, what do we actually know about the science of listening and storytelling and narrative? And it turns out to be relatively little. So this is going to be about a 5-minute talk. No, it's going to be about a 45-minute talk to review what we've learned scientifically about listening. I think what we all know is that really 2 basic facts. Almost probably every medical student knows these facts. The first one is the 11 to 17 second rule, which is, depending on which study you want to quote, doctors interrupt patients within 11 to 17 seconds of their opening their mouths. And the second one is William Osler's aphorism, listen to your patient, he is telling you the diagnosis. And that's sort of what we sort of have come away with when we think about the science of listening. But hopefully I'm going to share with you a lot more than just those 2 factoids. So why focus on clinical listening? I just spilled water, and I hope it's not going to go into any computer and blow things up. But why focus on listening? Well, first, the average outpatient clinician will conduct 100,000 medical interviews over the course of her career, making it easily the most common medical procedure that we do. Thanks, Michelle. And when you think about how carefully we learn how to carry out medical procedures relative to how vigorously we study and learn how to carry out the most common medical procedure, you can recognize a gap. In addition, most communication research has focused on what and how doctors should speak, what we should say, not on why and how we should listen. And listening is the sine qua non of effective healthcare because most practice, even in the most tech-driven fields, is based on patient reports of their symptoms, their disease self-management, and their experience of illness. Why else should we focus on listening? Most importantly, patients highly value being listened to, heard, understood, and taken seriously. Listening to patients is actually essential to alleviating suffering. Active and deep listening has been shown to be associated with greater trust, satisfaction, health outcomes at the patient level, and most importantly, perhaps, well-being at the clinician level. Listening has both instrumental and moral value, whose goal is to relieve suffering through either fixing when we can, witnessing when we can't, and ultimately transformation. And I will share with you an example of that kind of transformation later in my talk. And lastly, we focus on listening because it gets measured in our health systems. The CAP scores that we are all subject to have a couple of items that relate to how well your doctor listens to you and fully understands your history and story. So briefly, the outline of my talk is I will demonstrate how listening is involved in 4 of the so-called top 5 components of physician presence and connection. And then I will elucidate the 3 functions of clinical listening, which include task-focused listening, contextual listening, and relational listening. And I will then describe some recent research that sheds light on these specific functions. I'll first provide a basic roadmap for how I'm thinking about listening in the context of outpatient clinical care. As was mentioned by Lekshmi, I'm a general internist and primary care doctor. Most of what I do is outpatient care. And here, in the context of the medical home, you can see how a visit functions and flows. The patient comes into the medical home subject to social and environmental conditions outside of the clinical arena that they bring into the visit. And on the left side, you see that the clinician has a number of characteristics, as do the patient, that they bring to the visit. The patient and caregiver have different levels of health literacy, English proficiency, advocacy skills, and linguistic facility, including the ability to describe their own narrative. There are attributes of the relationship that impact the effectiveness of the clinical encounter, including the degree of trust that exists, whether or not there's a therapeutic alliance between patient and clinician, and the degree of continuity that exists in that relationship. And from the clinician vantage point, clinicians can or cannot have a certain kind of collaborative communication style that is closely aligned with the tendency to listen. Can have different levels of linguistic complexity with which they communicate with their patients, have different levels of experience with patient care, and with experience tends to come a greater respect for the science and art of listening, and then different degrees of curiosity, which is a secret sauce, secret part of the formula for listening, is maintaining one's curiosity. And in the visit, our job as clinicians is to do at least one of 2 things. That is to elicit from the patient and to explain to the patient. And in most communication research, as I mentioned earlier, much of the focus has been on doctors explaining things well, and very little has been focused on the degree to which we elicit, listen, and respond appropriately. So what do we need to elicit from the patient? Apart from their overall story, which I'll talk to you more about when I talk about contextual listening, at a most fundamental level, we're interested in the state of their disease. If they have heart failure, are they in class 2 or class 3? If they have diabetes, is it poorly controlled, well controlled? If they have depression, how severe is it? Then, what are the barriers to the self-management of that chronic illness? We need to elicit those. Few patients come in saying, actually, I'm not taking that medication because I can't afford it, or I'm not doing the physical activity because I'm so depressed. So we really need to be active listeners, seeking out barriers for self-management. And then the explanatory domains have to do with the things we think we know how to do well: give a diagnosis, explain a diagnosis, and provide a treatment plan and recommendations. And if we can achieve concordance across these domains in the context of a trusting, hopefully longitudinal relationship, we can achieve what is known as shared meaning, or in the field of Buddhism, shared mind. To achieve that state with your patient where you're talking about the same things, you're understanding each other on a deep level, and misunderstandings and miscommunications become more and more rare. Once we arrive at shared meaning, we are much better at making good clinical decisions. You can imagine, if you think your patient's got class 1 heart failure, but they actually have class 3, we may be making poor clinical decisions. So shared meaning and shared mind is associated with clinical decision-making and associated with better treatment adherence, which together, of course, can collaborate to achieve better health outcomes. So listening is inherent in this roadmap of the outpatient visit at a number of locations. Now, a really brilliant paper was published. The senior author was someone you may have heard of, Abraham Verghese, and it was a systematic review and mixed method study that tried to characterize practices to foster physician presence and connection with patients in the clinical encounter. As I said, this was a mixed method study. It involved a systematic review over 12 years. These 12 years were in the era of the electronic health record, so this is not some pre-digital age studies. It included observational research of encounters of highly skilled clinicians who were deemed to be masterful at connecting with patients, qualitative interviews with both physicians, clinicians, as well as other professionals who are in the listening fields, like social workers, customer service representatives, et cetera. And then a Delphi process to try to identify the top 5 practices that were deemed to be most effective and most feasible. They reviewed 73 studies of effective interpersonal interventions. These were randomized trials. 91% of them were level 1 randomized trials in the Oxford categorization system. So really very well done trials. And their outcomes included health in 52% of the time, patient experience 74% of the time, clinician experiences 37% of the time, and cost relevant outcomes 26% of the time. And after this, they generated the top 5 practices, as I said, based on the best evidence and feasibility of implementation. And they published their results in JAMA, and 4 of the 5 involve either directly or indirectly active listening. So the first, which you could argue has very little to do with listening, is to prepare with intention. The second is to listen intently and completely. The third is to agree with your patient on what matters most to them and to you. The fourth is to connect with the patient's story. The fifth is to explore emotional cues. These 4 of 5 involve, to one extent or another, listening. So let me break these down a little bit. Number 2 was listen intently. And I quote Oliver Wendell Holmes, who said, "It is the province of knowledge to speak, and it is the privilege of wisdom to listen." Trials of active listening have been associated with patient gains in rapport with their clinician, patients' understanding of their diagnosis and treatment plan, their satisfaction, and their perception of their physician's empathy. It's been associated with large reductions in such health outcomes as pain and anxiety, reductions in the so-called doorknob syndrome, which you're very familiar with, I'm sure, and has been shown to not require more time. Trials of active listening do not require more time. Now, you may find that paradoxical, but the fact of the matter is we have 20 minutes with a patient. That's what we have. And you get to decide what you want to do with it. Now, obviously, there are times when that visit goes on for 30 minutes and the visit goes on for 10 minutes, but on average, we get to decide what we do with the 20 minutes with our patient in a collaborative fashion. So these trials have shown that listening intently does not require more time. The third of the five is to agree on what matters most. An African proverb, famous African proverb, if you want to go fast, go alone. If you want to go far, go together. Collaborative agenda setting has been associated with higher patient ratings, reductions in pain and anxiety, and does increase the visit time by about 1 minute. You can imagine that to elicit the patient's agenda and to express yours and to come to agreement might take time. And in fact, that is the case. It's about 1 minute. Many would argue that it saves time on the back end, but in these studies, the overall visit time lengthened by 1 minute. The fourth of five was to be curious about patients' life and experiences. Holocaust survivor Elie Wiesel famously said, "We must see in every person a universe with its own secrets, with its own treasures, its own source of anguish, and with some measure of triumph." Being curious about patients' life and experiences in randomized trials has been shown to be associated with gains in satisfaction, reductions in healthcare use among frequent users of the healthcare system, reductions in racial bias, and fairly dramatic improvements in health outcomes because of the ability to contextualize care. And finally, in the top five of physician presence and connection is to explore emotional cues. Maya Angelou's famous quote, "People will forget what you did, but people will never forget how you made them feel." Exploring emotional cues has been shown in randomized controlled trials to be associated with gains in patient satisfaction, their ability to learn new information, their appointment adherence and treatment adherence, and improvements in health outcomes. One of the most dramatic studies in this category was a study of the treatment of the common cold that showed that patients whose physicians explored their emotional cues had a reduced severity of cold symptoms from 7 to 5.9 days. This was mediated by increased interleukin-8 levels, showing some sort of physiologic mechanism at the immune system level for exploring emotional cues. So I've given you the top five that Abraham Verghese team think of in terms of physician presence. And physician presence is obviously important for listening, as I've shown you, because 4 out of the 5 have to do with listening. But what does listening really entail in the clinical encounter? And I would argue, following the work of Mary Catherine Beach and Ron Epstein, that there are 3 types of listening: task-focused listening, contextual listening, and relational listening. Mary Catherine writes, "Good clinical practice involves listening with a diagnostic ear focusing on disease identification, a contextual ear focusing on circumstances and implications for disease management, and a relational ear focusing on the patient's experience of illness." And I would add, and then responding appropriately to what you hear. So what is task-focused listening? This largely involves clarifying patients' concerns and symptoms to arrive at an accurate diagnosis and ensure safe self-management. By that, I mean medication reconciliation may be one form of task-focused listening, very important to do. But clarifying patients' concerns to arrive at an accurate diagnosis requires pattern recognition, judgment, categorization, confronting one's confirmation bias, and facilitating clinical reasoning. Putting all these together is called the so-called diagnostic ear that we all strive to have. In contrast, contextual listening takes a more wide-angle view on the patient's life, recognizing that the meaning of and response to illnesses are conditioned by family, social supports, finances, education, literacy, resources, and structures of power. And this involves the so-called contextual ear. Finally, relational listening involves attending to, clarifying, and validating patients' concerns, values, beliefs, and emotions, and confirming shared understanding. This is the so-called relational ear. Connecting on these three foci of attention can create what is known as the shared mind that I mentioned earlier, an I-thou relationship in which clinicians' efforts align with what matters most to patients, and patients feel understood, validated, connected, safe, cared for, and known. This does not mean that we lose our own agenda in the process, but it does mean that we are aligning our agenda with what matters most to patients. Now, deep listening requires something known as epistemic reciprocity, which is reflecting a sincere belief that what another person says is valuable and giving it the attention it deserves. I just came from clinic this morning, which I had to cut short so I could make it here in time. And I would say this is a very challenging thing to maintain, right? You hear your patient start talking and you're like, yeah. Well, that has nothing to do with actually the temporomandibular pain that you have. So the ability to maintain a sincere belief that what another person says is valuable and giving it the attention deserves is a very important, highly honed skill. To best listen, again, thinking of this Buddhist notion of shared mind, we have to cultivate another Buddhist construct, which is the beginner's mind. Asking ourselves in the clinical encounter, what am I assuming here that might not be true? What might I not be hearing? What does this patient need from me today? What about this patient's context makes them unique? And then asking our patients, do I have this right? Reflecting back what you've heard. Tell me more. Can you explain in your own words what we just discussed? All of these elicitation moves promote active listening. Now, on to the research about these three foci of listening. What do we know about task-based listening? Well, I'm going to use the example, again, of heart failure and talk about discordance between patient and physician on patients' chronic disease status. We carried out a study in a cardiac clinic that primarily took care of heart failure patients to assess patient-physician concordance on New York Heart Association classification. And then after the visit, we asked the physicians what class of heart failure they thought the patient had, and we had already determined that a priori pre-visit with the patient. Physicians misestimated the class by greater or equal to 1 level in half of visits, including underestimating 75% of those who had class 4 heart failure. So our ability to assess the disease status of a patient, in this case with heart failure, seems to be unremarkable. We repeated this study in a rheumatology clinic. Here, again, looking for discordance, in this case, on a very importantly used measure in rheumatology, which is the Global Disease Severity Scale. We define discordance as greater than 25 millimeters on a 100 millimeter visual analog scale. That's felt to be clinically relevant discordance. Again, post visits, we asked the physicians their assessment of the patient's global disease severity, and physicians underestimated the disease severity in 30% of visits, and overestimated it in only 5%. Here in blue are patients' estimates of their severity, and in salmon are physicians' estimates of the severity. And this is separated into tertiles based on swollen joint count. So you can see the higher the swollen joint count, which is an objective finding for a rheumatologist, the more likely the rheumatologist is going to rate the patient's disease severity in a concordant manner, in contrast to when the patient does not have active swollen joint counts, but is reporting high disease activity. Demonstrating really the subjectivity that is inherent and that we need to overcome when we are doing active listening. Another form of task-based listening is to listen to how patients speak to us and to try to mirror their language back to them. This is another task-based kind of ear. And I'll share with you a randomized trial that's a little bit amusing of listening to patients' vocabulary and matching it versus not doing so and using medical terminology. In this study, all visits involve complaints related to sexual or excretory functions of anatomy, because these are often involve words that patients are not comfortable describing or don't know the terminology. So you hear a lot of things like, I'm itchy down there, and what have you. And in this case, physicians who matched their vocabulary with that used by their patients had patients with greater satisfaction, higher degrees of rapport, greater communication comfort, more distress relief, and a much greater intent to adhere to the recommended treatment. So matching the patient's language in this randomized trial of sexual and excretory complaints was associated with better outcomes. Now, we scaled up this study massively by studying secure messaging. This is a study that we carried out at Kaiser Permanente involving thousands of primary care physicians, tens of thousands of their patients, and hundreds of thousands of the secure messages that they've exchanged, all of these patients having diabetes. And what we did was we used natural language processing and machine learning to categorize physicians' language use as either having high or low linguistic complexity, and patients' language use in their secure messages as having either low or high health literacy. And then we determined at a dyadic level whether or not there was matching or non-matching of complexity with health literacy level. What we found was for patients who had limited health literacy, if their patient was discordant with them, in other words, if they had high complexity language that they used, their patient was 1.4, had a 1.4 greater odds of reporting poor understanding on their CAP scores. And CAP scores capture everything, not just secure messaging. They capture what happens in the in-person visit as well, as compared to dyads that had matching. So in other words, if you flip this around, those physicians who had the task-based ear to hear that their patient is using simple language and match that language in response had patients who came away from that secure message exchange and presumably from their inpatient encounter, or their outpatient encounters with greater understanding. This was at the dyadic level, one-on-one level. We then actually pursued an interesting sub-question, which is, you know, these physicians had many, many patients. And so we could characterize their communication style across their patients. Was it that they always matched the language with their patients, or was it random? Or did they use a universal precautions approach where they always use simple language? Or did they tailor their language to the language of their patient, no matter what that was? And we characterized 6 dominant patterns, which I won't go through here, other than saying on the left is the group that were universal tailorers. They listened to what and how the patient spoke and they matched it, versus universal precaution doctors, those who just assumed that the patient had limited health literacy and used simple language. And what we found for both patients with high and low health literacy was that those whose communication style tended more towards the universal tailoring, having that ear to tailor, had patients who reported better understanding in both the low and high health literacy group, and that there was no effect in contrast for the universal precautions group. And if you have the luxury of having a doctor who universally tailored and who happened to combine that with dyadic matching, and you had low health literacy, there were no communication disparities to be found. You were able to eliminate disparities in patient understanding by being a universal tailorer and matching that style specifically with your patient. Now, no one was a universal tailorer. It was just those who were closer to that tendency compared to those who were farther to that tendency. But again, showing you the importance of listening for simple task-based activities such as explanations. Now, the inverse of listening are things like lecturing or being verbally dominant. And there have been some studies on that in the task-based domain. In the oncology setting, Ali and Epstein showed that lecturing style in oncology was shown to be associated with worse patient understanding of their cancer prognosis. And obviously, cancer prognosis is a very important thing for a patient to come away from an oncology visit with. Similarly, a very famous, probably the most quoted communication study in medicine by Wendy Levinson showed that physicians' verbal dominance, as measured by tone and time, was associated with higher rates of malpractice claims among surgeons, irrespective of the surgical outcome. This is just how you communicate was associated with malpractice claims, and specifically verbal dominance being toxic to the encounter. Now, what about task-based listening and medical errors? You would think this would be the most important thing that we would study when it comes to listening. If I fail to listen, am I going to make a medical error? And it turns out this has been really understudied. And I'm going to share with you the only study that I found on this, which showed how failure to listen either, quote, destroyed the day in the case of a serious medical error, or, quote, saved the day in the case of a close call. Patients who were subject to medical errors or close calls and their families were surveyed and asked what caused the medical error in the case of mistakes, or what prevented the medical error in the case of the close call. In medical errors, 50% reported that the root cause was the clinician not listening or ignoring the patient and family's medical concerns. In close calls, 43% reported that the error was prevented by the patient and family being proactive and essentially forcing their clinical team to listen to what they had to say. So this is an area, I think, ripe for future study. Now let's switch. I talked about the first of the three foci being task-focused listening. Now let's talk about the second focus, which is contextual listening. And this is work done by a leader in the field, Saul Wiener at the University of Chicago, who talks about the importance of contextualizing care. And he describes contextualizing care as the process of adapting research evidence and evidence-based recommendations to match patients' life contexts. And he describes the method of contextualizing care as the 4C method. First, you identify a contextual flag. Let's say the blood pressure that the patient comes in with is 210/130, and you're thinking, something's going on here. And then you pursue that with a contextual probe. Once you find that contextual probe, you've identified a contextual factor that you can then use to adapt and create a contextualized care plan. That's the 4C method. And here in table 1, he describes examples of contextual factors that are frequent in outpatient care: access to care problems, competing responsibilities, difficulties with social support, financial problems, unsafe environments or unhealthy environments, lack of resources, skills, abilities, and knowledge, patient's emotional state, cultural perspectives, et cetera, attitudes towards the healthcare provider and the system. All of these are contextual factors that can influence whether or not a accurate diagnostic and treatment plan will be executed and implemented. And so there is a form of listening that is related to contextualizing care. What do we know about the effects of contextual listening and the provision of contextual care? Well, in our own work in heart failure, we've shown evidence of large gaps in physicians recognizing contextual barriers that their patients have. For example, 67% of the time, physicians were unaware that the patients had medication barriers to their CHF medications, and 69% were unaware of severe psychosocial barriers that were getting in the way of the patient's heart failure self-management. Saul Wiener has conducted 2 large studies of contextualized care involving over 5,000 patients in the VA healthcare system. The first was a stepped wedge design study that used an audit and feedback approach. For those of you who don't know what that is, it's something that happens post hoc. You record the visit, you audit the visit based on were the 4 C's, the 4C method done, and you provide feedback to that clinician on, hey, look, here you did really well. You picked up on this contextual red flag, you followed it up with a contextual probe, you found the contextual factor, and you contextualized care. Whereas here, you totally missed the contextual red flag, or you saw the red flag, but you didn't do a contextual probe. And so that's audit and feedback. It's a QI method. And using a step wedge design, his team showed that those in the intervention group were more likely to probe, were more likely to contextualize care, and were much more likely to find that contextualized care plans were associated with better health outcomes, like fewer missed appointments, better blood pressure on the next visit, better hemoglobin A1C on the next visit. He also found that the hospitalization rate in the intervention groups was about 2.5% lower than those in the comparison group, which calculated out to about $25 million in savings across these 5,000 patients. And he calculated the number needed to treat to follow up on one contextual red flag as 6, which is pretty good when you think about clinical epidemiology. He then, because it's very time consuming to do an audit and feedback intervention, as you can imagine, he then tried to repeat this study using a clinical decision support method. So in this study, patients underwent a pre-visit interview about contextual red flags. And as it turns out, I think, unfortunately, patients in both the intervention group and the comparison group, control group, were asked about contextual red flags. And in the intervention group, those patients who had contextual red flags, those physicians received electronic health record triggers in the intervention arm. And they found that physicians who received these triggers were more likely to probe, were more likely to contextualize care. But interestingly, there was no effect of the randomized trial on health outcomes. Although within each arm, contextualized care plans were strongly associated with better health outcomes, the clinical decision support intervention itself did not seem to yield better health outcomes. So a little mixed on that front. But I think any of you who practice in outpatient care understand the importance of contextualizing care. Otherwise, you're spitting in the wind, so to speak. Let's move now to relational listening, which I find to be the most interesting part of the listening game. Physicians generally, unfortunately, we are poorly attuned and poorly responsive to emotional clues offered by our patients during clinical encounters. A landmark direct observation study of clues carried out by Wendy Levinson in 2000, where she defined clues as direct or indirect comments about personal aspects of patients' lives and or their emotions, found that clues arose in over half of primary care visits. And in those visits, the mean number of clues was 2.6. 80% of those clues were psychological in nature and or social in nature. And we affirmatively responded to clues in only 20% of cases. Now, why might this be important? I'm going to totally shift gears and talk about what I think is one of the coolest studies I've ever seen. This is a functional MRI study that asked the question, might relational listening be therapeutic? And in addition, how might relational listening be therapeutic? So this functional MRI-based RCT attempted to determine the effects of active listening on a range of relevant outcomes and find their neural correlates. So let me describe to you what these Japanese investigators did. They basically took patients who had stories to tell about their lives, some form of either traumatic story or negative experience that they had in their life. The example given here is the loss of a pet. I'm going to talk about when my dog died. And they briefly described this loss, this episode, into a recorder. They then lay in the functional MRI machine, and their story was retold as they were lying, in their own words, as they were lying in the functional MRI machine. And while they're in the functional MRI machine, they're looking through the use of mirrors at an evaluator who you should think of as the clinician, whose job was to either demonstrate active listening or non-active listening, just through body actions. And patients were randomized to either the active listening or the non-active listening arms. And then only 20 seconds of the story was conveyed. So if I talked about the loss of my dog for 3 minutes, I only got to hear 20 seconds of it. And the evaluator only responded to 20 seconds of it. And this evaluator, by the way, was pre-recorded and, could have been AI for all it matters, but they were doing, coded to authentically look like active or non-active listeners. And then the patients rated the evaluator. Again, think of the evaluator as a clinician. And the MRI machine does what the MRI machine does, which is try to see where the signal is. So subjects randomized to the active listening arm reported much better impressions of the evaluators and greater rapport with these evaluators. They also reported a greater willingness to cooperate with the evaluator's recommendations if the evaluator were to make some recommendations. And then most interestingly, they were more likely to report a positive emotional response to their prior negative life episode as compared to when they heard that negative life episode that was responded to by a non-active listener. There was a reappraisal of their emotional response to their trauma by virtue of active listening. Now, what was going on in the brains of these people? There was more heated activity in two regions of the brain when you compare active listening to without active listening. The first is the ventral striatum, which is here in the midline, these red dots in the midline, which is located in the thalamus and is part of the limbic system, the reptilian brain. The reptilian brain and the limbic system lit up more when there was active listening than when there wasn't. The other part that lit up was the right insular cortex in the active listeners compared to the non-active listeners. Now, why is that important? Active listening, as I said, activated the ventral striatum in the thalamus, which is central to the reward process, the pleasure center. And the anterior or ventral striatum is that part of the reward process that is the critic. It decides if, okay, did that hit of cocaine that I just took, was that worth it? Was that really good? Am I having a warm glow because of the active listening that I was just subject to? So it's the critic, as opposed to the posterior stratum, which is the anticipatory part of the pleasure center. Like, I need my cocaine, I need my cocaine, I need my active listener. So the warm glow lit up in these patients. As I said, active listening also activated the right insula. Now, the right insula plays a role in feelings, both past and future feeling states. And changes in insular activation are responsible for emotional reappraisal based on reward-related activation. That's what the insula does. So these researchers concluded that perceiving active listening activates the reward system and improves the impression of past relevant experiences and current experiences. So it doesn't take a rocket scientist to understand why active listening in a clinical encounter might be therapeutic for our patients. Now, I want to give you some actual patient quotes and clinician quotes that demonstrate different forms of listening. I'm going to focus on relational listening. And here I'm working primarily from the work of Dr. Anita Hargrave, who's a junior faculty member at San Francisco General Hospital, who is leading something called the COMPASS study. And really, she's interested in how patients who have a history of adverse childhood experiences or adult trauma process or not process that history with their primary care clinicians, and how their clinicians respond, whether they inquire and how they respond to that trauma. And I'm going to just read what the patients and clinicians said about their relationships. And I want you to think about that fMRI study as I read to you. This is a patient with diabetes who's got a lot going on. I won't bore you with the details. Has had some trauma in her life, nothing terribly serious, but still for her traumatic. She had a recent death of her mother and other stressors. And she says to the interviewer who asked about their communication and relationship with their clinician, well, just being able to talk about it. I mean, I felt a big relief. I just started feeling better when I was able to talk to him. Talking to him, I felt better. And I started feeling, being able to, instead of just sitting there and doing nothing, I was able to move myself forward and try to get myself back on track. Just being able to talk to him and follow his instructions on what he tells me I need to do is, I feel it's made me recuperate from all my stuff. The clinician said, I feel like she felt she was heard. She felt like I would give her all the support that she needed, that if she needed help, she could come to me. I feel like I validated that I understood her. And I think that also secured our relationship even more, in that if I'm asking her to, if I suggest her to take the medications or having additional follow-up, she would be more likely that she's ready to do it, and she was ready to follow my lead, that she would be interested in hearing what I had to say. And because I was being supportive of her emotional stress, her grieving, and all that, I feel like she was willing to work with me to improve other parts of her health, such as diabetes in this case. So I think a very powerful example of that functional MRI study playing out in a real clinical vignette. Here's another vignette from the same study, a different patient. Patient says, it's like I was talking to my family. I've been with her for like 20 years. And by the way, it's been about 5 or 7 years that he's been with her. I've been with her for like 20 years. She asked me about it because there's a lot of addiction going around at that moment. And I was addicted to drugs, and she, seeing it, she could see stuff in me. Like, she really observed me. I mean, she's been the best, man. I can't say nothing else about it. It's like somebody, my auntie or mother, would notice things. She would notice things like that with me. And yeah, she's a good doctor. The clinician reports he's gone through a number of different traumas throughout different periods of his life, has a lot of resilience. He's been very open with me about the different things that he has gone through in his life. It's been a strong part of his history, and I think, obviously relates to, at different times, his mental health, his depression, and has overlays with his chronic pain as well. That often is worse when he's particularly down or has other stressful and traumatic events that he's experiencing. So it's definitely been something that we've engaged in talking about at various points through our relationship. The patient continues, we communicate eye to eye. Now, when you hear eye to eye, that's really mouth to ear. We'll talk about eye to eye in a minute in the Q&A portion. We communicate eye to eye, and now I'm so truthful with her. If me and my wife got into it or something, and I feel like relapsing or something like that, I could go to her and I could tell her, she'd give me advice and she'd tell me what would be bad for that. She's really in my life. I accept whatever she gives me because I know she tells me the right thing. I wouldn't see people as being more genuine than she is. The clinician says at different times, his ability is being in a place where he can engage with different multimodal strategies to manage his pain better. And I think him feeling like he has a supportive relationship with me at times have allowed, and I know what's going on in his life, and he can talk to me about those, to then talk about and for him to engage on pursuing other treatment modalities for his chronic pain. For example, that he may not necessarily normally be as into. So here we have an example, as I said earlier, of how active listening allows the patient to have greater trust in the clinician's recommendation and be more likely to follow that recommendation. Now, I just want to bring us down to earth and acknowledge that we know that there are a lot of barriers to active listening. We could have 5 grand rounds on the barriers to active listening. And I'm just going to focus here on one, which is multitasking, because I think this was a super cool study that Nita Ratana-Wangsa did. I was her mentor at the time. And this involved over 30 clinicians. Each bar here, each row is a different clinician in primary care and specialty care. And she was doing direct observation, including eye gaze work. And she was able to stratify the time that they spent in the visit into different categories related to working with the electronic health record or working directly with the patient. And the blue colors have to do with EHR use. Dark blue is silent EHR use. You're just sitting there typing on the electronic health record. The lighter blue is multitasking EHR use. You're like, yeah, tell me more. Yeah, oh, that must have been really hard for you. The light blue is using the EHR to educate the patient, and green are the times when we are actually directly eye to eye talking with the patient. So as you can see, I think a lot of time is spent multitasking, yet there are some of us who somehow magically, and I hope it's not pajama time, but some of us, and maybe it's just we're fast typists, do spend time listening to patients. And I'd say a good half of us spend at least half of our time interacting with patients, irrespective of the electronic health record. And I think with AI Scribe, there's great potential for this green color to become more and more dominant in our clinical encounters. But I just wanted to acknowledge that listening does come at a cost. And the question is going to be, what's more bang for your buck? And as Lekshmi said, listening is free, but is it really? It does come at a cost. So I want to conclude with a couple of thoughts. First, to remind us that whether you're a student or a faculty member, you either are or eventually will be known as an attending physician. And to attend has 2 meanings. And obviously the first meaning is to care for, but to attend really means to closely listen. Attention and listening are 2 sides of the same coin. And to be a good attending physician means to be an outstanding listener. I like to say that you can tell how good a doctor is by how well she listens and by the questions she asks. Others would have other definitions of what a good doctor is, but active listening is a critical and consequential component to the clinical encounter. There are 3 broad categories of listening: task focused, contextual, and relational listening, all of which work in tandem to optimize care. And the field of clinical listening is understudied, and the impact of active listening, in my opinion, has been underestimated. I want to quote Elizabeth Toll in a really incredible opinion piece that she published in JAMA Internal Medicine called The Work of Deep Doctoring, where she writes, undivided attention is a core to deep listening. It invites the patient to tell their full story and the physician to listen with openness and curiosity without judgment. It allows for solution shop work, not production line work. I totally love that line. Solution shop work, not production line work. It moves us away from the industrial model of a series of individual transactions towards a more human model with multifaceted solutions emerging from relationships, merging trusted relationships with our patients, teams, and colleagues with the tools of centralized medical data, the internet of knowledge, and the potential of AI will allow us to engage in the deep work at the heart of our profession. So hopefully an optimistic note to end on. And I like to think of my clinic visits and my patient care as rowing upstream with my patient, that you have a choice. You know you got to go upstream, and either you can try to go upstream together or you can fight each other and end up just going in circles. And so hopefully, I've convinced you that active listening is one means to row upstream together. And I'll stop there and open it up to Q&A. Thanks a lot. Can we keep the slides up?
Sure.
Because I had some backup slides.
Of course. Well, thank you so much, Dr. Schillinger, for your amazing talk. We have some questions from the audience already. There's over 70 people listening, hopefully actively online. So
doing functional MRIs.
Doing functional MRIs. Dr. Panelat asks, thanks for an inspirational talk and your work. And something we don't often talk about in the clinical encounter is how do we express love to our patients? So, colleagues and Dr. Panelat himself have experienced this concept of expressing love for your patient. Do you think that love is part of kind of a mediator of what's going on? And do you think it's helpful to speak or think about it in the patient encounter?
Thanks, Steve. That's a great question. I do think love is a component of what we do. And I definitely tell some of my patients, I love you, man, or love you. And they definitely say that to me a lot. And there are definitely lots of hugs. And it definitely fills me up. So I think if you're authentic about it, and if you're not worried about offending the patient in some way, if you're, what's that term? Your sixth sense is that expressing your love to the patient is going to add value, I think you should feel free to do it. I think the very act of active listening is a form of love. Think about your own relationships that you have with your loved ones and the times in which you're like blowing them off and the times in which you're really, really focused on what they have to say and how much love that person feels when you do that. So in short, I'd say go for it with some caution, and not every patient is going to engender that kind of feeling in you, and not every physician is going to engender that feeling from their patients.
Thank you so much. Another question from the audience, one of our listeners, Dr. Obaid, was talking about, is there training available at UCSF and beyond to train to practice these three different types of listening that you powerfully outlined?
That's a great question that I wish I knew the answer to. I'm not that closely connected to the communication curriculum in the medical school and in the residency. I would say that the concept of active listening, deep listening, shared mind definitely is something that is conveyed. Whether we practice it and assess each other in OSCEs, I would tend to doubt that we do that. But I'd have to defer to those who are in charge of that part of the curriculum.
Yeah, I will, of course, put in a plug for our amazing relationship-centered communication courses. I see Dr. Murad in the audience, who's one of the amazing facilitators of that workshop. And they talk a lot about a lot of the concepts you raised here. And I'm sure your book has a lot of practical tools as well. A faculty member reached out to me before your talk to say, this is amazing. I want to listen more. How do I physically do it when the patient's list is overflowing and I have 20 minutes and one room? How would you advise them?
Yeah, I really am a believer that you have 20 minutes and you get to decide what you want to do with the 20 minutes. And it's really being really mindful of every second and the choices you're making every second of that 20 minutes, and being super strategic about it, can help you become a better listener. The trials that I mentioned that show that active listening and curiosity were associated with better outcomes did a very simple thing. They basically instructed the physician to wait 90 seconds before they interrupted the patient. That was their active listening intervention. So what comes after that, I don't know. A lot of good things come from that, but I think try it out. Just try it out, and try asking different questions in response to the ones that you're normally used to asking. And be mindful and experiment. This is the most common medical procedure you're going to do. You want to hone that skill and try it out. No one is going to be offended by you listening to them.
And last but not least, I can't help but channel Dr. Wachter. If he were here, he would definitely ask you about if the promise of AI scribes to improve listening is something that is hope, hype, or somewhere in between.
Yeah, I think this is one of the most important research questions in the next year that we want to answer, and I hope we can answer it at UCSF. I can share a slide that was shared with me by Sarah Murray and her team. This is a patient quote after a visit in the pulmonary clinic. This is what this patient said, patient 1370. Post-lung, excellent visit. Dr. X was testing a new AI program which allowed him to speak directly to me. No typing, just eye to eye. Simply spectacular. I hope it works out for the clinic. So you remember I said eye to eye, it may mean mouth to ear. So I am hopeful that as the AI scribe becomes more and more sophisticated, that this will free up more of our time to be active listeners. Now, there is another twist to the AI story. If I can go back a slide. Very soon, you're going to see published in the journal Nature a tool produced by Google DeepMind called Amy, which basically is a simulated doctor. And they've done unbelievable work in simulating physicians' question asking and diagnosis making and treatment recommendations. And the long and short of it is, it outperforms primary care clinicians in nearly every domain, including empathy, openness and honesty, and active listening. And so we can see a time when some of the listening could be done by AI, not the relational listening, but some of it could be done by AI and be fed to us, and we, in a mindful way, integrate what the patient is saying in their story. And then we can continue to navigate the clinical encounter without having that black box in front of us. So I'm hopeful, as Dr. Toll was in her final statements on the deep work of doctoring, that AI will help us become better listeners and help us build stronger relationships with our patients. We have to have that happen. And in fact, the American College of Physicians, is the last slide, recently came out with its position statement about AI. And its first two positions are, this has got to help the relationship, it's got to help us listen. So now, obviously, they've got a stake in the game. They're American College of Physicians, they want physicians to have jobs. But I think clearly AI should be thought of as something to enhance patient care in that way.
Wonderful talk with lots of food for thought and practical strategies. Thank you all for coming. Thanks again, Dr. Schillinger.
Thank you.